In 10% of all prostate cancers, PSMA PET scans are not an option, and this is due to the fact that those types of prostate cancers do not produce that specific type of molecule. So today, Dr. Mark Schulz, who's a 30-year medical oncologist focusing solely in prostate cancer, is going to discuss what the options are for patients in this category. Dr. Schulz, we know that PSMA PET scans have been around and approved in the US here since 2021, and to my knowledge they work where the PSMA sends a tracer out and it attaches itself to prostate cancer cells in the body, and then it lights up on the PSMA scan because of that molecule. So, 10% of prostate cancer patients do not have that type of molecule where the PSMA PET scan can either attach or it doesn't work. So can you kind of shed some more light on this situation, and then really what do we do?
Right. The scan has been such a big breakthrough, transforming the field of prostate cancer in my judgment. This is the biggest breakthrough since the discovery of PSA. Imagine a scan, and we've gone over this before, but imagine a scan that is very accurate at detecting prostate cancer anywhere in the body and detecting prostate cancer specifically, because the other scans that we've used in the past, MRI and CAT scan and bone scans, they detect the disturbance from an abnormality, but they don't specify that that disturbance is necessarily prostate cancer. It could be in an area of inflammation, it could be other intervening factors. So PSMA PET scan says it's prostate cancer. Wow, what an incredible technology, and has altered the way we manage prostate cancer in my day-to-day practice in a very substantial way. As you point out, 10% of the patients have a type of prostate cancer that is not going to register on the scan. And that can create issues. If someone does a scan and it doesn't show any metastasis, that doesn't tell us there are no metastasis if that individual has PSMA-negative prostate cancer, which the number of 10% is thrown around. I think that 10% figure is more common in advanced disease. It seems to be less common in newly diagnosed patients. But I did have a patient just recently who had biopsy-proven Gleason 4+3 in his prostate. And almost invariably, when you do a PSMA PET scan in these individuals, the spot in the prostate will light up, and if they have any metastatic disease, it would also light up. In this individual, he had a PSMA PET scan, and it didn't show any metastasis, but it also did not show any activity at all in the prostate cancer. So this is a newly diagnosed patient with PSMA-negative prostate cancer. And I had to kind of think through, we've had PSMA PET scans for a couple of years now, what to do. And we're going to order an Axumin PET scan, which is kind of like if PSMA PET scans are third generation, Axumin was second generation, and then bone scans and CAT scans were first generation scans. Axumin is more accurate than bone scans and CAT scans, but less accurate than PSMA PET scans. So we're going to get an Axumin PET scan. I don't know if we're going to still be able to manage him, and if the Axumin lights up in the prostate and shows no metastasis, can we treat this patient the same way we would treat who had a PSMA PET scan that shows no metastasis but also lights up in the prostate, showing that the scan works? The answer is unclear in my mind as I'm thinking through this, because we know Axumin PET scans are not as powerful at finding small amounts of metastatic disease as a PSMA PET scan is. And we may not be bold enough to abandon the traditional approach to an intermediate risk prostate cancer, so-called TEAL in the color system that PCRI uses, which is to give 4 months of hormone therapy and consider prophylactic radiation to the pelvic lymph nodes. These patients have significant, not an overwhelmingly high, but a significant risk of pelvic lymph node metastasis. So as a precaution, we talk about 4 months of hormones with some pelvic lymph node radiation, in addition to whatever treatment is administered to the prostate to eradicate the primary tumor. This situation is not common in newly diagnosed patients. I don't think it's anywhere near 10%, but it does happen. And people need to be aware of the fact that if the PET scan shows no metastasis, sure, that's good news. But if it doesn't light up in the prostate itself, where we know the tumor is, that's a sign that it's a PSMA-negative tumor. And the fact that it's not showing any metastasis is meaningless, because we know that that scan has been rendered inactive or ineffective in that particular individual.
Before I get to my next question, please click that subscribe button. When you do this, it tells YouTube that this video was helpful for you, and they'll push out our videos to other people who are searching for prostate cancer answers on this platform. Also, if you would like to join our cause, you can do so at pcri.org/donate. Now back to my conversation with Dr. Schulz. So when you say that Axumin is not as effective as PSMA PET scans at being able to find prostate cancer, what is that percentage margin? So if PSMA PET scans are 90%, what would Axumin land at?
I don't know that those numbers have been provided to us, but let's say 70% rather than 90% or 60%. It's been studied most carefully in men that have what's called a PSA relapse, where we know that if your PSA is 0.5 and someone who's had surgery and the cancer is coming back, so the PSA has risen up to 0.5 after surgery, signaling the cancer is back, PSMA PET scans are going to find the location of the cancer 50% of the time. An Axumin PET scan is not going to function anywhere near that well in that setting. Maybe 10% of patients, it'll show where it is. The PSA has to be higher. It's just a less sensitive scan. It's a useful scan, and I think it's a logical thing to do in a PSMA-negative patient. But it doesn't approach the precision and accuracy of PSMA.
Is there anything else besides Axumin? Because before PSMA came into play, we heard about F18 with a certain specialist or choline. Is there anything that's still available in that realm?
In talking about patients who are PSMA PET negative, this situation is going to arise more frequently in people with advanced metastatic disease, where they can have some lesions, some metastatic sites that are going to light up with one type of scan, and others will light up with a different type of scan. And my usual sequence here on the West Coast is if the PSMA is negative, consider getting an Axumin PET scan, whether newly diagnosed or metastatic. And then the next level would be to get something called an FDG PET scan. These are commonly used for lymphomas, lung cancers, breast cancers. Not typically for prostate cancer, but they can be useful in patients who are otherwise PSMA negative. And then you mentioned choline, which is a type of scan that's really only available at the Mayo Clinic. And it is a useful scan. It's just inconvenient having to fly to Rochester to get a scan, but it is a useful scan. Something to consider in people who are PSMA negative. And how do you know they're PSMA negative? Well, the situation may arise where you've got someone's had an MRI or a CAT scan in these advanced patients. They can see that there's something going on in the bones or the lymph nodes, but it's not lighting up. Or it may be lighting up in one area but not in another. This is a signal to us that we might want to consider getting one of these additional PET scans to try and get the full picture, the full extent of the metastatic disease. Thus, the treatment that we design will be more accurate for that individual.
Forgive, the percentage grade. I'm just trying to give the patients a construct. So if PSMA is 90%, Axumin is 70%, where does FDG and choline come in?
So I would probably think that choline is going to be more accurate in prostate cancer patients than FDG. I only mention FDG because that's widely available, whereas for choline, you're going to have one center that I'm aware of in the country, which is the Mayo Clinic. So I would pick choline as even the next choice, possibly equally as good as Axumin, maybe even slightly better. But due to its inaccessibility, that's why I offer a different sequence. These scans are all potentially useful, and it is a bit of an exploratory process, as is the field of oncology. Every patient is different, and some will have different patterns of disease, different patterns of scans will work. Having an idea of what's available to people so that they can go down a checklist and make sure that they're covering all their bases to understand to the best of their knowledge where the cancer is, how much is out there, or how well it's responding to treatment. These are critical factors in designing optimal treatment protocols.
So a question I've seen come up a couple times is that if a patient has had a PSMA PET scan and it doesn't show anything in the prostate or in the other parts of the body, do they need to get another one to make sure that they are not PSMA, they don't have that molecule. And so they're kind of wondering, do we retest? Is this a fluke? Is it kind of based on the center, or does this really mean one and done? This is not an option for me.
Well, this situation probably comes up most frequently in what we call the PSA relapse stage of prostate cancer, so-called indigo in the PCRI color system. Rising PSAs, historically, before we had PET scans, you had to have a PSA of 25 before a scan would show anything. And the policy in that era was just give people hormone treatment. Don't even bother to get a scan. Then we got the Axumin PET scans, which started to detect where the cancer is in these relapsing patients with PSAs as low as 1, which was truly remarkable. And when PSMA came along, they said you can potentially detect cancer all the way down to a PSA of 0.2, which is phenomenal. But we do know through experience that only about 20% of men are going to light up with such tiny amounts of disease. The PSA is only 0.2. There's not much cancer there. And it's not that the cancer is PSMA PET negative. It's just that there's so little that the scan can't detect it. As the PSA goes up, say 0.5, as I mentioned before, the chances of a PSMA PET scan finding the disease is around 50-50. And as you get up around 1 plus, you're looking at maybe 90% of the time you're going to pick up the location of where the cancer is. So it's not just the fact that some cancers are PSMA PET negative. It's also in certain situations there's so little cancer that the scan just is unable to detect it. The approach is very similar to what I already described. It's sort of a trial and error. In light of this knowledge, we're not going to go get choline scans or FDG scans or Axumin PET scans in PSAs less than 1, because from history we know that those aren't going to show any disease. But as the PSA starts going above 1, if the PSMA PET scan continues to be negative, then we start thinking of layering on these additional scans to see if we can find out where the disease is located.
Going back to your original case study where you were talking about this new patient who has a 4+3, so they're in intermediate, what we would call high intermediate, prostate cancer. And they are now, looking at what treatment options they have. Does it make sense that any patient where PSMA doesn't work out, that patient automatically has to go on hormone therapy and there's no question about it?
The way we present these intermediate risk patients to the patients themselves is we'll try and give them an estimate of what's the percent likelihood that there's some disease outside the prostate that the scans aren't seeing. This is an issue we've dealt with historically with prostate cancer, with all cancers. What's the chance of metastasis? And then how likely is it that if you do additional treatment, hormone treatment or radiate the pelvic lymph nodes, that you'll be able to cross that person over from someone who's theoretically doomed to a relapse someday to someone who actually gets cured. And this is variable depending on how high the PSA is, how many cores are positive, what the Gleason score shows, and a process that has been in the decision-making realm of prostate cancer for 30 years. What one does is impart the statistics of what's the chance of cancer being out there, how much can this additional treatment reduce that risk, and what kind of side effects is this additional treatment likely to incur, and then allow the patient themselves to participate in this decision. The intermediate risk, or the teal category, is the most challenging in this regard because most of these patients are not at high risk for metastatic disease. They're at low but not zero risk. As patients get into the high-risk category, it's pretty much a foregone conclusion. You're going to add additional treatment because the risk of micrometastatic disease is much higher.
So much of, deciding what type of prostate cancer treatments you get is really making sure you know what type of cancer that you have. And with PSMA PET, being an option, but now not being an option in these 10% of patients, if that's not an option for them, would something like genetic testing really give them more information about their prostate cancer and help them maybe decide what direction to go based off of their risk score?
Yes, so in many ways, we're very wealthy in the prostate world compared to other cancers. We've had PSA for a long time. And PSA that's at zero level doesn't mean there's no cancer, but it does mean you're in a complete remission, and you're not likely to find anything on scans. As PSA starts to creep up and the scans are negative, is there a way to cross-check and confirm the presence of occult disease somewhere? And the answer is yes, with what's called cell-free DNA. Companies like Foundation One or Garden 360, a simple blood test, can detect cancer DNA in the bloodstream at very, very low levels. And sometimes even when men have PSAs that are zero. So it is a nice way to cross-check the status of people. Some men have had surgery in the past and their PSAs lingering at 0.2, 0.3, 0.4. And a simple blood test to look for cancer-related DNA in the bloodstream is a nice way to cross-check, even though the scans may be clear, as to whether these patients have some residual cancer that is lurking somewhere, and can confirm it independently other than just the PSA by itself.
So when we're talking about PET scans, we're talking about imaging the whole body. Now, I think that one of the things that patients kind of get concerned about is, okay, well, does the PET scan, not using PSMA, am I going to have as much information in the prostate area with the lymph nodes as I would, if it had worked? But can you talk about how MRI and the 3T MRI is very advanced? Even before we had PSMA PET scans, we were using 3T MRI primarily. So how does that mix in with the Axumin PET scan to give us the best picture of what's going on?
Right, so MRI imaging inside the prostate is superior to PET scan. And so MRI still has a very important role in deciding treatment and monitoring for relapse and all these things. However, the capacity of MRI to look at, say, pelvic lymph nodes is limited by the fact that it doesn't really see the cancer inside the lymph nodes. It only sees the outer dimensions of the lymph nodes. So that means that the cancer in the lymph node has to become so voluminous that the lymph node is expanded beyond a certain threshold, usually about 10 millimeters, before the reader is going to start talking about the lymph nodes as being potentially cancerous. So relative to a PSMA PET scan, the MRIs are really quite crude at detecting lymph node disease. There is a type of MRI called diffusion-weighted imaging, and there's also another modification that's available over in Europe called Combidex, which can detect very small amounts of cancer in the lymph nodes using MRI technology. The PET scans have been so successful, these other options have been superseded, but in people who are PSMA PET negative, Combidex or diffusion-weighted imaging of the lymph nodes is a potential option as well.
So besides MRI, Axumin scans, some of the other scans that you mentioned, and genetic testing, is there anything that a patient needs to look for and pay attention to for people who may be in this category?
I think my last comment would be that while these scans are much more push buttons, historically with MRIs of the prostate, we ask patients to exercise a lot of care about the quality of the readout. It's tricky to read MRIs of the prostate accurately, and you need a lot of experience and a lot of training. PSMA PET scans are a little more push button, a little more straightforward. But in so many areas of medicine and just in life in general, quality does matter. When things just aren't adding up like you would expect them, and you say, well, why am I expecting something? People with intermediate risk disease, most of them don't have metastatic lymph node disease. So when we find it, it's a little unexpected. So I would always exercise care that if someone's saying there's metastatic lymph node disease, especially if they're just like one spot, there is always a possibility of a bad read or an errant outcome. None of these scans are perfect. Everything needs to be put in the context of what we're expecting. And when there's uncertainty, it is possible to get a second read of the scans or repeat it or get a different scan. It's super important to try and be as accurate as possible at staging because it's going to affect how intense the treatment is and thus also the side effects of treatment.
So in these situations, it's very important to advocate for yourself. PSMA PET scans may not be an option. I know you hear us talk a lot about them on the channel, but the options that Dr. Scholes mentioned before we had PSMA PET scans were very heavily utilized. And as you've heard him say, they are quite effective in gathering information and giving you a good picture of what's happening in the prostate and around the body. So I would really, stress the fact that you need to advocate for yourself, have a medical team who is working with you, answering your questions, and I would bring up these options to them and say, is this an option for me? And at least if you find out it isn't, you'll know why. You want to make sure you have a shared decision-making experience and you have that dialogue with your medical team because you are important. Your prostate cancer is, different from any other person's, and you want to make sure that you're treating it strategically. And all the information that he mentioned will help lead to that strategic plan. And of course, you want to make sure that you're building the current plan and the future plan for treatment and always know what the next steps are. So that medical team and that discussion and making sure you're comfortable with them is very important and a huge part of advocating for yourself. Now, if you need help knowing more information about, any of the things that Dr. Scholes talked about today, you can talk to our helpline. These are prostate cancer patients who give information, not advice, but they've been through a lot and they have been trained by our medical oncology team, and so they have a lot of information to give. And you can contact them at pcri.org/helpline. Now, support groups are also a great option. I think that the more and more that I work in this prostate cancer community, the more I want to see people connect, because I've seen such powerful conversations and information shared between patients. You know, when you have that shared experience, it's really a bond that a lot of patients can have. And I think when you're going through a hard thing, community is so important. So I'm going to go ahead and link those support groups in the description below this video. Now, if you have topics and questions that you would like us to cover, go ahead and leave them in the comment section below this video. We do read our comment section, and we do pick up a lot of our ideas from there. We want to make sure that we're answering your questions and we're getting to the heart of the matter. And so if you can please just make sure that you leave your comments and your questions, it's very helpful for us, because we're going to be producing a lot more videos this year on prostate cancer, and we want to make sure that we get to those. Now, thank you so much for watching. Thank you for trusting us. Please remember that you're not alone. Build the community around you. Remember that you need support and you need to take care of yourself on a mental, spiritual, and emotional level. You are so important, and I hope you have a great week.